Which is the first-line drug for type 2 diabetes mellitus?
Metformin is the first-line drug
Why is metformin preferred?
because it effectively lowers blood glucose, does not cause hypoglycemia when used alone, is weight neutral or causes mild weight loss, and has a favorable cardiovascular safety profile.
How does metformin lower blood glucose?
It decreases hepatic glucose production and improves insulin sensitivity.
Can you be more specific?
Yes, sir. Metformin primarily decreases hepatic gluconeogenesis. It also increases peripheral glucose uptake in skeletal muscle and improves insulin sensitivity.
Does metformin stimulate insulin secretion?
No, sir,
And why is that important?
because it explains why metformin rarely causes hypoglycemia when used as monotherapy.
What are the adverse effects of metformin?
The common adverse effects are nausea, abdominal discomfort, diarrhea, and metallic taste. A rare but serious adverse effect is lactic acidosis.
When is metformin contraindicated?
In severe renal impairment and conditions predisposing to lactic acidosis.
What important drug interaction should you remember for metformin?
Alcohol increases the risk of lactic acidosis. Iodinated contrast media may cause renal impairment, leading to metformin accumulation and lactic acidosis.
Now let us move to sulfonylureas. Can you name some examples?
Glibenclamide, glipizide, gliclazide, and glimepiride.
What is their mechanism of action?
They stimulate insulin secretion from pancreatic beta cells.
How exactly?
They block ATP-sensitive potassium channels in beta cells, causing membrane depolarization. This opens voltage-gated calcium channels, leading to calcium influx and insulin release.
What is the major adverse effect of sulfonylureas?
Hypoglycemia,
Any other adverse effect?
weight gain.
Suppose an elderly patient has recurrent hypoglycemia while taking glibenclamide. What would you do?
I would consider reducing the dose or switching to a drug with lower hypoglycemia risk, such as metformin, a DPP-4 inhibitor, or an SGLT2 inhibitor.
Excellent. Which drugs can increase sulfonylurea induced hypoglycemia?
Salicylates, warfarin, sulfonamides, azole antifungals, and fluoroquinolones.
Why do they increase hypoglycemia?
They either displace sulfonylureas from plasma protein binding sites or inhibit their hepatic metabolism, increasing plasma drug levels.
Now tell me about meglitinides.
Meglitinides include ripaglinide and neteglinide.
How are they different from sulfonylureas?
They also stimulate insulin secretion but have a shorter duration of action.
What is the clinical advantage?
They are useful for controlling postprandial hypoglycemia and generally produce less prolonged hypoglycemia.
What are alpha-glucosidase inhibitors?
Acarbose, miglitol, and voglibose.
How do alpha-glucosidase inhibitors work?
They inhibit alpha-glucosidase enzymes in the intestinal brush border, delaying carbohydrate digestion and glucose absorption.
When are alpha-glucosidase inhibitors most effective?
For controlling postprandial blood glucose levels.
What adverse effects are commonly seen with alpha-glucosidase inhibitors?
Flatulence, abdominal discomfort, and diarrhea due to fermentation of unabsorbed carbohydrates in the intestine.
What is the mechanism of pioglitazone?
It activates PPAR gamma receptors, improving insulin sensitivity in adipose tissue, skeletal muscle, and liver.
What is the major advantage of pioglitazone?
It reduces insulin resistance, which is a key defect in type 2 diabetes mellitus.
And the major adverse effects of pioglitazone?
Weight gain, edema, fluid retention, and worsening of heart failure.
Would you use pioglitazone in a patient with heart failure?
No, sir. It should generally be avoided because fluid retention may worsen heart failure.
What are DPP-4 inhibitors?
DPP-4 inhibitors, also called gliptins, are drugs that inhibit the enzyme dipeptidyl peptidase 4, thereby increasing endogenous incretin levels.
Can you name some examples?
Sitagliptin, linagliptin, vildagliptin, saxagliptin, allogliptin, teneligliptin, gemigliptin, and evogliptin.
How do incretins lower blood glucose?
They increase glucose-dependent insulin secretion and suppress glucagon release.
You said glucose dependent. Why is that important?
Because insulin secretion increases only when blood glucose is elevated. Therefore, DPP-4 inhibitors have a very low risk of hypoglycemia when used alone.
Excellent. What are the advantages of DPP-4 inhibitors?
They are weight neutral, have a low hypoglycemia risk, and are generally well tolerated.
Which DPP-4 inhibitor is preferred in chronic kidney disease?
Linagliptin,
Why?
because it does not require dose adjustment in renal impairment.
Good. What important drug interaction should you remember?
Ketoconazole can increase saxagliptin levels by inhibiting CYP3A4, while rifampicin can reduce the effectiveness of some DPP-4 inhibitors.
Now let us move to GLP-1 receptor agonists. Can you name a few?
Exenatide, liraglutide, dulaglutide, semaglutide, and lixisenatide.
How are they different from DPP-4 inhibitors?
DPP-4 inhibitors increase endogenous incretin levels, whereas GLP-1 receptor agonists directly stimulate GLP-1 receptors.
What are the major actions of GLP-1 receptor agonists?
They increase insulin secretion, decrease glucagon secretion, delay gastric emptying, and reduce appetite.
Which of these actions helps patients lose weight?
Reduced appetite and delayed gastric emptying.
Very good. In which type of patient would you particularly prefer a GLP-1 receptor agonist?
In overweight or obese patients with type 2 diabetes mellitus.
Any additional benefit?
Yes, sir. Some agents such as liraglutide and semaglutide have proven cardiovascular benefits.
Excellent. What adverse effects are commonly seen?
Nausea, vomiting, and gastrointestinal discomfort.
Now let's discuss SGLT2 inhibitors. Name some examples.
Dapagliflozin, empagliflozin, canagliflozin, and ertugliflozin.
What is their mechanism of action?
They inhibit sodium glucose cotransporter 2 in the proximal renal tubule, reducing glucose reabsorption and increasing urinary glucose excretion.
So where do they act?
In the kidney, specifically the proximal convoluted tubule.
What benefits do SGLT2 inhibitors provide beyond glucose lowering?
They cause weight loss, reduce blood pressure, provide cardiovascular protection, and offer renal protection.
Which patients particularly benefit from these drugs?
Patients with established cardiovascular disease, heart failure, or chronic kidney disease.
Good. What adverse effects should you remember?
Genital fungal infections, urinary tract infections, dehydration, hypotension, and rarely euglycemic diabetic ketoacidosis.
Excellent. Suppose you have an obese patient with type 2 diabetes. Which drugs would you prefer?
Metformin, GLP-1 receptor agonists, and SGLT2 inhibitors.
Why not sulfonylureas?
Because sulfonylureas can cause weight gain.
Now consider an elderly patient who frequently skips meals. Which drugs would you avoid?
Sulfonylureas, Meglitinides, and insulin because of the risk of hypoglycemia.
Which drugs would you prefer?
Metformin, DPP-4 inhibitors, SGLT2 inhibitors, or GLP-1 receptor agonists.
Very good. A diabetic patient has established cardiovascular disease. Which anti-diabetic drugs are preferred?
SGLT2 inhibitors and GLP-1 receptor agonists because they reduce cardiovascular events and mortality.
A patient has chronic kidney disease. Which drugs are preferred?
SGLT2 inhibitors, GLP-1 receptor agonists, and linagliptin.
And which drug may become contraindicated in severe renal failure?
Metformin.
Excellent. Now a clinical scenario. A newly diagnosed patient presents with HbA1c of 11% and blood glucose of 350 milligrams per deciliter. Which therapy would you prefer?
Insulin therapy.
Why not start with oral drugs?
Because severe hyperglycemia requires rapid glycemic control. Insulin is the most effective glucose-lowering agent and helps reduce glucotoxicity quickly.
Very good. One final question. Which newer anti-diabetic drug class currently offers the most impressive combination of glucose lowering, weight reduction, and cardiovascular benefit?
GLP-1 receptor agonists, especially semaglutide, although SGLT2 inhibitors also provide major cardiovascular and renal benefits.
Excellent. That is a balanced answer.